All right, so good evening and a warm welcome to all the dignitaries present here. I'm Ankita from Clarnet, assigned as a session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet is a digital partner for this event organized by National Neonatology Forum. And the topic of today's session is NNF Shine Week 3 North Zone. So let's begin today's session, for which I would like to invite Dr. Suksham ma'am to take over. Over to you, but before that, I'm muting everyone.
Everybody, please mute everyone.
I'm muting everyone because for the smooth running of the program, and once only the lecturer presents the lecture, they can unmute themselves directly.
Thank you. And thank you, Pratima, NNF, Dr. Surender, Dr. Sushma, and Tapas for organizing this session and initiative so that our postgraduate students become more confident. They are already doing it. So what I would say is all of you are already managing, but one has to learn in a structured manner how to manage them. And first and foremost thing, all of you should remember, we are doctors. We are here to save life. So once we are here to save life, only extra thing that we have to learn is saving it in a structured manner so that we don't land up in a guilt that we could not manage the baby and it would have been better managed if I knew this. So I'm just trying to share my screen. I hope it's visible to all. Is my screen visible? Hello? Hello? Am I visible and audible?
Yes, ma'am, you're audible, but your network connection is little unstable.
Okay, I'll just check. Otherwise, should not cause a problem. If it will, then let me know. Okay. So, for the residents, wherever you feel that you want to interrupt me by raising a hand or in chat, you can do that. And more so, I would love if in the chat a question raised by a resident is being answered by other resident. It will help me in understanding that you have got the concept right and you are there to learn in a structured manner. So I just want you people to concentrate on this skin. Look at the faces of these mothers. If you look at the face of the first mother, she is worried and she is taking care of the baby. Look at her hand. We call it as containment, but look at her hand, her face. She has some worries for the small babies. The other mother seems a bit peaceful. She knows that she has to tube feed the baby, holding the tube, holding the baby. And look at this mother who is giving care in KMC care to the baby while baby is on CPAP and also giving tube feeds. And this mother, when she becomes comfortable, look at her face and smile. Look at this twin mother. So this smile, this confidence comes with the care which we provide and the confidence we show in them. And we have to make them confident that major part is being done by them. We are just the resource person for the same. Why are we so much worried? Is this low birth weight or small same as when we pick and choose our clothes? Okay, this I'm a bit thin, so I would fit in small size. I'm a bit fat. I think I fit in medium. It's okay. I'm happy with my body size and I am going to fit in extra large. What if all four of them are of same age, but the size? It's okay. So what, my brain is same, my thinking power is same, I'm okay with my body size. No, it's not the same here in case of the babies. Why it is not same? It's not just simply a small size or a medium size versus extra large size or large size. The problem here is it's not the physical size only which is matter. It's these babies who are low birth weight, most of the time they are preterm also. Organs are there, all organs are there. They are laid as early as starting from 1 month up to 4 months, and then after they are just maturing after 4.5 to 5 months. But this maturation will happen in utero only in a better manner as compared to ex utero. So when these babies have come out, then their maturation is going to be affected by the external environment which is there. And if you look at all the organs, including the respiratory organ for which we remains worried so much, look at the alveoli, look at the vessels, their number, their immune system, their gut microbiota, whereby we are actually not paying much of the attention when we are writing antibiotics inadvertently. Look at the baby's brain, all of these are there, but the maturity is less. So it's not small versus extra large size. And for our Indian purpose, we take 2500 gram as a normal weight. It can vary according to various nations. If the baby is less than 2500 gram, we say that we are dealing with a low birth weight baby. Here we are talking only of the weight, nothing to do with the gestation. So firstly, we are talking only in terms of weight. When we call of low birth weight, only weight. Then we will see whether they are preterm or term. Then why are we further dividing? Why I gave this example of small, medium? It's the same thing. Here, less than 1000 gram, 1500 gram, 2500 gram, the issue is going to be more prominent as the weight decreases. And when we start corroborating it with gestation, now let's see how are we able to fit this low birth weight and gestation hand in hand. So we call all the babies born before 37 weeks as preterm. But is the preterm who is born at 23 weeks same as preterm born at 36 weeks? So the issue is going to be different. It's not going to be the same. And very simple, the smaller the gestation, the issue is going to be more prominent. So for the purpose of development or for the purpose of dealing, we can't deal with every gestation separately. Few of the gestation where the most of the problems are common, most of the management is common, they have been clubbed up under various gestation steps. For example, hello, hello. I hope I'm audible. So if we club up this gestation of less than 27 weeks, less than 28 weeks towards one side, whereby the problems are much more difficult, so they are extreme preterm. Then comes the strata of very preterm, 28 to less than 32 weeks. And then moderate to late preterm. Here also moderate preterm, 32 to 34 weeks, a bit of difficult as compared to 35, 36 week or late preterm. So that is why this broad category of prematurity is divided, because the management is going to be different at different levels in terms of monitoring, in terms of management, in terms of their issues. Now comes, can a baby who is born at 37 weeks also low birth weight? Yes, this baby can also be low birth weight. This is a preterm baby. And this is a baby who is born at term but weight is less. Look at this baby. Classical look of old man type, whereby head size is normal. The baby's length is also okay. But look at the baby who is fat, muscle mass is very less. So this is giving a classical look of old man type. And this baby might be 38 to 41 weeker, but the weight is less than 2500 grams. So how would we come to know whether this baby is appropriate for gestation, small or large? For this, commonly we are using these charts, intergrowth chart. You people might be also reading your pediatrics book where the Lubchenco chart were there, and hand to hand, side by side, there are these intergrowth chart. So these intergrowth charts, especially for more than 32 weeks, these are longitudinal also. So any baby who is falling, these charts have got various centile. The centile is 10th centile, 3rd, 10th, 50th, 90th, and 97th centile. When this baby is falling less than 10th centile, then we call the baby small for gestation. When the baby is falling more than 90th centile, you look at these two red lines. So the upper one is for large for gestation, because more than 90th, it is at 97th. And this one is the baby, he is less than 10th centile at 3rd centile. So this baby is small for gestation. And if we look at the x-axis horizontal line. So any baby who is born before 37 weeks is preterm, then after term, after 41 weeks, 41 plus 6 weeks, the baby becomes postterm. So these charts are being uh, good charts to use in a sense, because from 33 weeks, these are the only chart that are longitudinal charts. Factors. All of you get messed up with this list of risk factors. One thing always remember, any deviation from normal is to be explored. So the baby is less than 2.5 kg or baby is less than 37 weeks. So you have to find out the reason. These reasons may be X, Y, Z, exhaustive list, very difficult to learn, to do with mother, to do with baby, to do with the different strata of age, extremes of age, and previous premature birth. Very high chance, more than 25%, that the next pregnancy will also be premature. Nowadays, lots of mothers are undergoing IVF conception. It itself is a risk factor. The chance of prematurity with them is high. God designed this womb for a single baby. If the multiple pregnancies are happening, again, it's risk factor. The baby may be lying in utero in various positions. This may be breech, this may be transverse lie, again a risk factor. Where the baby is lying in the uterus. So any anomaly in this entire assembly of uterus, cervix, placenta, again a issue. Any infection which may be acute, chronic, placental infection, maternal conditions. So this is how you can club up rather than mugging up this list. Otherwise, you will land up in issues of memorizing it. And only thing that you always should remember, any deviation from normal should be explored. Now, gestation age nowadays, our mothers, even the uneducated mothers, they know their LMP. Hardly there are mothers who doesn't know LMP. If you are dealing with 100 mothers, hardly one will be there who doesn't know LMP. Although first trimester ultrasound may be there or may not be there in up to 50%, 60%, first trimester ultrasound is usually missing. It is there after second trimester for an anomaly scan. Now, how will we as clinician come to know if LMP is also not there, and you don't have even your antenatal ultrasound of first trimester, which is giving the dates, which is giving the exact gestation? How would we go? So what we look at the physical parameters. Again, how would I memorize this list? 6 physical parameters, 6 neurological parameters. Very easy. I'll just tell you it's a science. Don't mug it up. Just understand. Look at the skin. Look at this skin. This is a very shiny skin. Look at this skin and look at this skin. So as the skin maturity increases, the color which is shiny is not as shiny. It becomes slightly roughened because melanin is now there. And look at these hair. Are these hair normal? No, this is not a normal hair. This is a normal hair. So these thin lanagu hair, if they are in abundance, that means this baby is preterm. So more shiny the skin, the more is the preterm, and you will keep on scoring accordingly, going up to -1 and -2 also, 0, -1, -2. So rough idea is that more the shiny, more the preterm, more the lanagu hair, more the preterm. As the lanagu hair keeps on decreasing, the baby is becoming mature. From running from 1, 2, 3, 4, 5 is the maximum score. So for scoring, you need a chart, but for an overall generalized assessment, I'm just giving you the simple tips. Look at the skin shininess, look at the lanagu hair, and look at their abundance. Now look at this baby. This is the hairy pinna. This is the pinna, and you have to just fold it and see how it is coming back. Recoil. Skin has got elasticity. If this is the pinna, this is going to recoil very slowly. This will recoil very quickly. The way when we fold our ear, they come back quickly. It's a ear recoil that will help us to know. So simple, slow to rapid recoil, and again scoring goes from 0 to 5. Now look at this breast mount. The skin, there's no breast nodule. It's totally flat. If you look at this, then there is some bud coming. Then the bud increases in size. And as it increases, again, we keep on grading as -1, 0, 1, 2, 3. So now look at the creases. If you look at the creases of this baby, there is hardly any crease in the anterior upper 1/3 only, upper 1/3 only. And now if you look at this baby, the whole foot is creased. So from no crease to increased creases, your maturity increases. So instead of mugging up the entire list, just try to understand no hair, Lenagu, no hair, it is in the reverse manner. If it is there, that means preterm. Shiny skin, preterm. As the skin matures, the shininess decreases. Creases, flat to occurrence of all creases. No breast mount to breast mount of a good size of more than 5 millimeter. So these are the skin parameters. Neurological, I'm not discussing. Even if you do at the skin parameters, each parameter has got a good validity. So you can find out whether the child is preterm or not. Now there is left with the genitalia. And if you look at the female genitalia, the labias are separated, the male genitalia. If you look at this, complete rugosities are there. So from absent rugosities to complete rugosity, color, and testes might be here, somewhere here in this baby. They are starting to descend. You can see the bulge. And here the testes have already descended. So bulge is here. Same way, labia, which was totally separated, it will keep on covering the labia majora will cover the labia minora. So from not covering to covering, and from scrotal no ridge to ridge and descending of the testes. So simply this will keep on scoring from 0 to 5. Now we have lots of problems with these babies. Any chat question in between if you want before I go with the problems? Or should I take them in the end only? You want me to take them in the end? Hello, you want me to take them in the end? Okay, I'll take them in the end. So these babies, we classically think that asphyxia is more of a problem in a term baby. No, asphyxia is a problem in all, whether preterm or term. And we have to show our results to our obstetric counterpart that we are able to save these babies. Then only they deliver by cesarean. If they are delivering a baby, delayed delivering of this preterm baby, the baby will be asphyxiated. So this is what baby asphyxia is not related to term or preterm. Asphyxia is related to in utero insult. So preterm baby can be asphyxiated, a term baby can be asphyxiated. All of us know the Apgar scores well, and then we can keep on scoring them. Then comes the biggest issue of hypothermia. So if you want to imagine, it's beyond your imagination that the baby can lose up to 1 degree in 1 minute. The baby is born in utero, 38-degree temperature of the liquor, and ex utero after 1 minute this will be 37, and then it will be 36 after 2 minutes. By the time you have resuscitated the baby in 3 minutes, the temperature would go down to 35 degree, so which is actually moderate hypothermia. So receiving this baby in a wrap, because they are losing the temperature very rapidly, they are not losing like 0.1 to 0.3 degree per minute like a term baby. Feeding difficulties, all of us have seen this situation. Baby is not able to breastfeed. We have to go by gavage feeding, or we have to go by palliative feeding. I'll just tell you later on about the feeding. These babies then have got issues of respiratory distress, retractions. If you see from the side, intercostal retraction, if they're mild, or if you see if they're severe, these can be seen from the front also. Then another issue, you must have seen this type of pictures. So they have the issue of intracranial hemorrhage. Even the lateral ventricles will have blood. These babies, they keep on having cessation of breathing in between, which we call as apnea, if it is occurring for 20 seconds or 10 seconds with cyanosis. So it is very common intermittent apnea, but don't give this diagnosis of exclusion that this baby is preterm. Apnea to hote rehte hain. Preterm hai, so apnea will happen. No, it's not that every apnea to be labeled because of the prematurity. If the frequency has increased, it has to be explored. It has to be looked into what is the reason behind. And this you will be dealt in detail once the neurological issues are dealt. So only thing here I want to point out is, if the frequency from the previous frequency has increased, if there are more than 2 occurring in 6 hours, or 2 to 3 in 6 hours, or the one which is needing bag and mask, don't label it to prematurity, and don't label it to obstruction. Every time you are busy with your suction catheter and releasing it, saying that it is because of the obstruction. If the frequency is increased, explore the reason. Now, retinopathy of prematurity. Actually, we are having currently almost like a epidemic of this condition, which is there in developing country, because lots of babies are being saved in SNCUs, but the provision for screening of retinopathy of prematurity is not full-fledged over there. They are referred and then they might be lost to follow-up. But this has no reversible damage. It's irreversible if grade 3, more than grade 3 has happened, whereby partial or complete retinal detachment will keep on happening. So who are these babies? Again, we dealt with the weight less than 1500 gram. You are happy by giving 100% oxygen. Your ventilator oxygen is going on 100%, compressor is not working, labor room 100% oxygen. These are the most prominent problem. Baby being put on 10 liters 100% under head box oxygen. These are quite commonly given, and believe me, this is one of a very big factor for inadvertent use of oxygen, of antibiotics, of transfusion, giving it without understanding the guidelines. 8, 9, giving transfusion to a baby who is not sick, or the baby is having hemorrhage, baby had jaundice, you did DVT, all these are risk factors for retinopathy of prematurity. That is why we are seeing them in bigger babies. And one of the biggest issue is inadvertent use of oxygen. Oxygen is a very toxic drug. Oxygen is a toxic drug. So I'm saying it under full consensus. Now look at this baby. This thing we most of the time forget, or when we send a ENT call, we get a reply that baby is not cooperating, or we get behavior assessment, BOA, which they normally do. And in that they say the hearing is normal. But you can buy this handheld device, OAE, and these clips also, they are not very costly. And this can be done by the staff nurse or by the doctor on duty itself. Although it has got a false positivity, but still, despite false positivity, OAE should be done in all these babies, because we are keeping them under high alarms, meningitis, jaundice, lots of risk factors in these babies, which we are not understanding that can cause hearing effects in these babies. Tone anomalies. Later on, the baby will have anemia of prematurity. So these problems, simply labeling that baby was preterm, that is why baby is having anemia at 8 weeks, 10 weeks, or 12 weeks, is not correct. We have to prevent it also. We have to give confidence to our obstetric counterpart that how they can do the delayed cord clamping by keeping the baby receiving on the abdomen of the mother. Or if the baby has not cried, then only you take the baby to the warmer. So don't do inadvertent sampling. Just simply labeling it to physiological PEEP will not do. We have to prevent it also. Now we also talked about another baby who was SGA. So this baby was born at term, but baby was low birth weight at the same time. And this baby was low birth weight at the same time. So what could be the additional problem? Here nobody is asking you a theory question like you used to have in MBBS. You would write down the same problems for low birth weight, same problem for SGA. There are some certain peculiar problems with SGA. And I'll just discuss those peculiar problem only. One of this is polycythemia. And this color, classical color, you may not get in all the babies. So you have to screen also. So screening for polycythemia at 2 hours and 12 hours, looking at the PCV, because if you don't look at this, the baby might be having respiratory distress, feed intolerance, and every time you would land up in labeling this to be because of the baby having sepsis. You'll start with antibiotics, baby is not going to respond. Only thing is, you will start the baby on fluid, some fluid relaxation. The fluid is going in the intravascular space. The baby will respond to fluid rather than to antibiotics, and you will have a false perception that baby had sepsis and responded to antibiotics. So please, these babies should be screened for polycythemia. Looking at the PCV, central lab value, not only by the capillary one, because 5% high value is there when you squeeze it. And at 3 months, the symptoms are there or PCV is more than 70%. You also need to have a PCV reader to find it out as polycythemia. Another issue is meconium aspiration. Again, meconium aspiration is not only a domain for a term baby. It does happen in baby who is growth retarded. Why growth retarded baby? Because the liquor inside may be less. There might be uteroplacental insufficiency and meconium aspiration happen. So passing of meconium is not restricted to a baby who is 40, 41, 43 weaker. Any decrease in liquor will pre-expose them to meconium. Rest of the problems, agreed, they are same: hypothermia, hypoglycemia. But please be very careful with polycythemia and meconium aspiration in babies who are SGA. Now, I'll just talk about the broad management about these babies, because it's difficult to cover the entire low birth weight and its management in one lecture. It's a complete science. So we will just talk about the broad things and not in depth, because in depth every issue will be taken up separately. So this is, you can understand more of an outline and a bit in detail about the feeding of these babies, nutrition of these babies. So best is if you get somebody asks you that I want to refer this baby to your outbound unit, just tell them refer the mother. We will deliver the mother here and we'll take care of the baby. So better is in utero transfer. Now this baby who is born less than at term, less than 37 weeks, but less than 2500 gram, do all these baby need to go to ICU? No. All these babies doesn't need to be nice. The baby who is less than 1800 gram may land up in your secondary level care ICU, which we call as SNCU, specialized newborn care units. Those who are more than 1800 gram, they can be in the postnatal ward. But if they had been sick, if there was asphyxia, if there was meconium aspiration, these are for the stable babies. And obviously, this does not mean that your monitoring will not happen. You have to monitor these babies for vitals, for sugars, for your polycythemia, urine stool in first 48 hours carefully, and feeding, of course. Now, once they are at home, that this does not mean you can discharge them within 24 hours. So they have to be observed for all this for 48 hours plus. So how the mother is now worried, how would I keep my baby warm? So she would come to you by making the baby wear a very thick woolen sweater. It's not about the thickness, it's about the layering. So that in between the two layers, air does not go. This is our purpose. So you can just tell a very simple line to mother, one layer extra to what you are wearing. So what the mother is wearing, so one layer just extra to that. Okay. So that will help her in understanding what to do. And feet and head covered, additional line. So feet and limbs covered with one layer extra. Rest is all just, mugging up that put a blanket, put a warm cloth above, below, and all those things. Once in the hospital, very small baby, maybe in a radiant warmer, the bigger one by the side of mother, and preferably all these in kangaroo mother care. Now I want you to look at this chart carefully. Okay, just a minute. So this chart we are going to discuss a bit, because this is related to the feeding, nutrition. Nutrition separately, I don't think it is being covered in depth. So I'll, even if it is covered, I'll just deal with certain salient points of nutrition. One thing is, don't keep baby NPO. So some feeding has to go on until and unless your baby is less than 26 weeks ADF or ADF. If you are not confident, until unless your baby is less than 28 weeks. So we don't want you to jump directly to what tertiary care centers are doing, but at least you can bring improvement one by one gestation. So why we are saying so? Because nutrition will need three things: suck, swallow, and breathing. Okay. So this baby who is small as less than 30 weeks, the baby does not coordinate the swallowing with the breath. If the baby is not coordinating swallowing with the breath, can you give pallid feed? Can you give spoon feed? No. So this baby has to undergo a passive feeding, which is by putting a gavage feeding. Here you can put a orogastric. We don't put nasogastric feeds. After a few days, once the baby has matured, the same baby will land up in katori spoon feeds once the 30 weeks has happened or 1 week postnatal life has happened. Now comes a slightly bigger baby who is more than 30 weeks. This baby has a coordinated swallow and breathing, but still sucking is poor. If you look, these babies, when they suck, you won't hear that noise which of the baby, that negative suction which the baby has to generate. The baby has to suck, and then only the baby will pause. So the burst which a baby takes, that noise is not there. The number of burst is less before 34 weeks. But coordination with breathing is there until unless baby is sick. Baby is on inotropes, baby is having multiple seizures, intubated on all those. The baby is just on room air or some nasal cannula oxygen, then this baby is having a good coordination of your swallowing and breathing. So this baby can be given katori spoon feed. And more than 34 weeks, direct breastfeeding. So this is how, what mode you will give for the feeding. Now, when to start, how much to escalate, and by what time reaching to the full feeds, I'll just touch upon, not going into too much of depth of it. Only and only one thing remember, don't keep any baby NPO. If you are not very confident, like in a tertiary care center, where by 30 week at after 24 hours or within 24 hours on full feed, but do start the feeds. Starting in babies more than 28 weekers by 15 ml, 20 ml per kg body weight per day, and then escalating by 15 to 20 ml per kg. This is minimum which is needed. I'm not talking of, once you have mastered on this, then you can reach to the same level of gestation by gestation, starting full feeds in all these babies right from the birth, because that is doable, not causing problem. But once you have gained the confidence, then that step will come. Don't keep NPU. Now there are lots of evidence whereby oral colostrum, the oral painting of the colostrum is done, and it's quite useful. So there's no need to keep this baby nil permeable. As far as the fluid requirement is concerned, so once you are on fluid, that does not mean feed can't be given. That much amount which is there in the feed can be subtracted from the fluid, starting by 16 to 80 ml per kg and increasing by 15 to 20 ml. As far as radiant warmers are concerned, there's no need to add extra. Just do oiling and no extra 20 ml or 40 ml of phototherapy or radiant warmer, because nowadays phototherapies are all are cold phototherapy of the LED light. They are not warm, hot blood, these bulbs and all. So these babies are going to lose some weight, and we have to understand how much weight they are losing, which is a normal physiological loss, which will happen up to 5 to 7 days in a term. But here we are talking of preterm, they would lose up to 9th, 10th day before they start regaining the weight. Now, what other things? Exclusive breastfeeding is exclusive breastfeeding plus supplements. Why these supplements? All of these supplements are actually transferred from mother to baby in utero in predominantly in third trimester. The baby is born early third trimester. So you need to give these. The stores are not there in the baby. Hello? Hello?
Sheila, wet.
There are, pardon? Hello? There's some noises. So now looking at what all is needed. You gave vitamin K at birth, 0.5 mg or 1 mg depending upon the weight. So that was at birth. Now you have to give vitamin D. So vitamin D to these babies, very small, 800 international unit, otherwise 400 international unit per day. But check your HMF sachet. If you are giving HMF, if you are, then some amount of vitamin D is going from that also. Hello? It's there in the feeds also. So you don't have to overload these babies simply by adding the syrup. The amount which you are adding in the drops plus the amount which is there in the feed and HMF, all calculated together has to be 400 to 800 international unit per day. Coming to the iron, iron can be started by 2 to 4 weeks, 2 to 4 milligram per kg body weight per day. So these again in form of drops is better because they are concentrated, and preferably the one which has got iron plus folic acid. Now this your multivitamin, just read the composition of vitamin A and D. Don't just let the patient buy any vitamin whereby vitamin A and D are not in appropriate dose. Otherwise, the baby may land up in having excess of these, which can have various symptoms. Calcium phosphorus, any calcium phosphorus syrup, but the ratio of calcium is to phosphorus has to be maintained at least 1.7 is to 1. So, or if you don't remember that, 2 times calcium and 1 time phosphorus, this should be there. So this discharge, whatever we are doing, don't just a day before or on the day of discharge give the booklet. Now today you will be discharged. At that time, then you will miss up all this. There's something called as pre-discharge planning. Obviously, it keeps on going continuously, but a feel of that I'll be discharged in a day or so. So that 48 to 72 hours before, a proper discharge planning has to begin. For this, you will have to look at weight gain for 3 consecutive days. This does not mean if baby was 1200 gram or gaining 3 days 30 gram, so I'll discharge. No. So ideally 1800 grams. If you are having a very busy unit, 1500, 1600 is your cutoff. Look for 3 consecutive days for a weight gain. And the biggest factor is, even if weight gain is there, mother is not confident, you cannot. That means something was lacking previously also in our counseling. So mother, if we were doing a continuous counseling, so mother is very confident, and usually this factor will not come if we were previously also meticulously counseling. You may not be counseling each mother, just stand in the bay of a cubicle in the middle and counsel all the mother, and a separate counseling if there is a more problem in any particular mother. You can make a mother champion. They understand each other very well. So counseling has to go on a continuous manner. This will give the mother confidence, and this issue of mother being not confident before discharge will not be there. Nutritional supplements, we have already learned how to add them. They are added usually once the baby's feed has reached 100 ml per kg and is tolerating for 1 to 2 days, maximum 3 days, then you add them. As far as iron is concerned, it is added slightly late by 2-3 weeks. Immunization. So once the baby has come out of the ICUs, give immunization to this baby. BCG OPE. If this baby is staying with you for 3 months, very preterm, please don't forget to discharge the baby without your pentavalent vaccines. And obviously kangaroo mother care, right from the beginning, right from the birth, at discharge and at home, this should continue. So this mother, you can give a danger signs booklet, you can explain to her, but these has to be in a local language. Over here in North India, we are giving in Hindi, but whatever state you belong to, I'll just show you this Hindi chart which we have put in our unit also. It's a holistic chart for common morbidities up to first few days when she has to go to doctor. If there's a abdomen distension, vomiting, diarrhea, the baby is cyanosed, the baby is having seizures, icterus, the baby is becoming cold by the touch method as assessed by the mother, intercostal retractions, and if the baby is having seizures. And if you look at the above 3 pictures, they are just a simple counseling, not for going to the doctor, that she has to give exclusive breastfeeding for 6 months. The vaccination should happen and kangaroo mother care should go on. This one single chart, we have displayed it in the unit for a continuous you can say a pictorial counseling of these mothers. Now, when we are doing a follow-up, we must, right from the beginning, once the baby is there, every birth weight, then achieving of the birth weight once the baby has lost. After that, how many days after the birth weight the baby reached to the on which day, 10th day, 14th day, regained the birth weight, then a plotting of the weight every week. This should go on like a serial growth monitoring, and the same thing has to happen once the baby is coming to follow up. After 40 weeks, we can also use these WHO charts, MGRS chart, because MGRS chart, one of the site was India also, and they are quite good in babies who are more than 40 weeks, once they have reached to 40 weeks. The screening, I've already told that these problems are there and this screening should happen, especially of ROP. 1 month is a very good time. If you don't remember anything, just remember at 1 month I have to do ROP screening. I'm saying 34 weeks if has happened, the hearing should happen. By this time, there 7 days, 21 days, one ultrasound had to be there. So 1 month has happened. I have to look at anemia. I have to look at osteopenia of prematurity. I have to look at sodium. So this neonatal period, 28 days or 1 month, do all these tests. Other than ultrasound, which should be done early as 3 to 7 days, one ultrasound should be there. So this is what I meant by when I said plot these growth of the baby on a growth chart, weight, head circumference, and length. If you look, this is being plotted for this baby, 26 weeker, every week, so that you know where the baby is falling, and I have to intervene. If you don't intervene in between, you have lots of issues with these babies. ROP is one of the important issues of failure to thrive, and failure to thrive, infections, apneas, osteopenias in these babies. So intervene when we see that this dip, which is a natural dip, physiological fall, and after that baby is not gaining, started gaining, again dipped. So here you have to find out the reason why my baby dipped and how I should intervene. This baby is under a continuous dipping. So this baby is continuously following a low line. These babies need to be intervened. So when we call a preterm, the very first answer any would say, any resident, when we say how to manage low birth weight, start from the prevention. Ma'am, I'll prevent prematurity. Can we prevent prematurity? It's a holistic thing. So just talk of the things which you can do, and rest of the things has to go on as a broad global improvement. For you, for prematurity prevention, which can be done at your level, is antenatal steroids and magnesium sulfate. Magnesium sulfate is more for the neuroprotection, and steroids is for the maturity of the lungs. So I thought, let me just give just a single holistic chart for you to understand what are the important points when you have to manage a low birth weight baby. Starting from the antenatal period, antenatal corticosteroids, all mothers less than 34 weeks. Definitely, we are not talking of other late preterm and all, where the evidence is there. Antenatal corticosteroids. Place of delivery should be a facility, so in utero transfer, whereby you can manage these babies. First, golden hour management has to be appropriate, otherwise you will land up later on in issues of ROP, BPD, inadvertent oxygen use, ROP, BPD, because you could kept on intubating the baby. You didn't do the proper management in golden hour, and BPD will happen. Keep the baby with mother, prevent sepsis. Every time this hand washing like an obsession should go on, and keeping the baby in kangaroo mother care. At least the babies who are in CPAP, they can be approved with a lesser MAP, can be kept in kangaroo mother care. Nutrition, just remember one thing, don't keep any baby NPO until and unless it's a surgical abdomen. The baby is having shock on inotropes. Even the seizures is not a contraindication. It has to do with the neurological system, not with the gut, that you are stopping the feed. Some feed has to go on, and ventilation has to be gentle. This baby very gently being managed and CPAP in prone position also. So this is not everything, but this is something which should be done minimal by all, and this will, believe me, save lots of lives as intact saving, not only the saving. And this is all I have to say. And now I think we can take up any chats, question and all if they are there. Hello. Hello. So is there anything in the chat? Not audible. This was somewhere at I don't know. I tried to find out in between if I'm audible or not, but I didn't listen in bit. I didn't open the chat in between. Hello, hello, hello. Anybody now? You can. All of you are muted. I don't know. The organizers admin has to unmute for any questions. I tried to finish before time so that you can land up in discussion. And one thing I'm very clear, human brains have a capacity to listen to anybody. So no lecture should, according to me, exceed 45 minutes to 50 minutes. Because here, it's not a two-way interaction going on. And human brain loses the interaction after 45 minutes. It's a known, very well studied fact. That is why I tried to finish in 45 minutes. So that you people can interact. If there is some possibility by chats, or let me open up the chat box. Is SMOF a recommendation? What is SMOF? I don't go by the small term. Ma'am, IUGR with Doppler changes to be kept NPO. So Doppler, I'll go one by one. Doppler changes with are of various types. One is reduced end diastolic flow, one is your absent end diastolic flow, and one is your reversal of end diastolic flow. All in umbilical artery. I'm talking of umbilical artery. Reduced end diastolic flow, nothing to be done. Now coming to your absent end diastolic flow in the umbilical artery. So what you do is there's nothing by clock car. Go to the baby, listen to the bowel sounds. Gas reaches in the stomach by 6 hours, rectum by 12 hours. 4 to 6 hours is the time and the gas will reach to the stomach. So if the bowel sounds are there, we have to start the feeds. I'm talking of absent end diastolic flow. Baby more than 28 weeks, absent end diastolic flow. The moment the bowel sounds come, they may come at 2 hours, you can start at 2 hours. But if you are not confident, at least by 6 hours. Again, R is a very bad thing, just auscultate the bowel sounds. So by 2 to 6 hours, bowel sound will come. Start the feed. Smaller baby, start by 10 to 15 ml per kg. Bigger baby, 15 to 20 ml. Slightly more bigger, 32 weeks and all, you can start by 20 to 30 ml per kg. And 34 weeks and beyond, no need to look at absent and diastolic flow. Half feed, half fluid, or complete feed. Coming to the reverse end diastolic flow. So I told these are of various types. Reverse and reduce, both are different. So that is why nowadays all the obstetrician write down for reduce is decreased, DEDF. So it's not any terminology, it's just ultrasound finding. If they've written REDF, just reconfirm it is not reduced, it is reversal. In case of reversal, you have to wait for 24 hours if the baby is small. What is the SMOF? Please don't write down the short forms. I don't like the short forms or any slang. So this person, Dr. Pagya, you can retype what do you want to understand by SMOF. Then please show the slide with danger signs in Hindi. So I have given the slides to the admins. You can take, Dr. Pratima has the slides. She can share with you. I don't keep anything hidden. So these are all black and white. You can make your own booklets. We have made a booklet in Hindi also, which we give to the mothers at discharge. Ma'am, can we get the slide? The slides are there with Dr. Pratima. It's with the NNF. So NNF has to decide. I don't have access to you people. What is the difference between IUGR versus SGA? So IUGR and SGA should not be used as synonym. SGA is a term which we look at the centile chart, simply weight less than 10 centile or more than 90th centile. Whereas intrauterine growth, IUGR is intrauterine growth retardation. This baby became SGA was intrauterine growth retarded. You can confront it like that also. What is the difference? Why did the baby become lesser weight? The baby must have been growth retarded. But you have to look at the parameters and you have to document in the ultrasound that there was intrauterine growth retardation. Then only you can call it as IUGR. To call it as FGR, because it is happening in utero, fetal period. So there are on 2 occasions being documented with fetal growth retardation, then only you call it. Simply by looking at weight, you cannot call them. Your here very high chance of your Doppler anomalies also. Lipids and TPN, SMOF lipids and TPN. So I didn't talk of the TPN here. It's another separate topic. If you are using TPN, so and SMOF lipid is available, then you should use it. Otherwise, I think nowadays it's the soybean lipid combined with other parameters, but fish oil obviously is not coming in India. So SMOF is available, then you can use. Fresenius is selling the lipids in India. And intralipid, usually it has got only predominantly soybean as component. So, ma'am, what are the necessary investigation to be done in any LBW baby? In any low birth weight baby. So again, don't use low birth weight and SGA synonym. If the baby is low birth weight, so you should do a sugar monitoring, which we call it as hypoglycemia. These babies can land up in hypoglycemia. So sugar monitoring at 2 hours, 6 hours, 6 hourly for 72 hours. This is one monitoring. You have your TCD monitor. So look at the transcutaneous bilirubinometry. This has been very well validated in babies 32, 33 weeker also. It's not that babies 32 weeker, you can't do it. But a value less than 8 on transcutaneous bilirubinometry or more than 13 is not validated. So here you need to do a prick and you need to do a microbilirubinometer and look at this. So hypoglycemia monitoring, if SGA, then you have to do also your polycythemia monitoring. SGA, not all the low birth weight. So sugar is the only thing that is needed. But if this baby was born to mother with PROM and is having symptoms, so we are talking only of the low birth weight, nothing else. Rest depends upon the symptoms. Respiratory symptoms, you have to do an X-ray. Baby, mother having risk factor for sepsis, and baby symptomatic also. Then there is a separate set of investigation. We are not doing any sepsis screen in early onset. You may confront on that. You simply take the blood culture, take the X-ray, start the antibiotics, see the backtech and then stop. That depends upon the resources. So only low birth weight, hypoglycemia monitoring. All babies less than 2500 gram per hypoglycemia monitoring has to go on. And SGA, a polycythemia monitoring at 2 and 12 hours. Anything else? You can go to the GMCH website. There's a Hindi booklet also. You can make, actually what I do is I don't believe in that one should, you take an idea from these and make them in your own language. Make them in your, you can innovate something more in these. So this is for giving ideas only. You can give to the mothers a booklet written in your local language, whichever state you belong to. But most of our mothers are not well versed with English, so don't venture into giving them in English. I am speaking in English because you are from different states. So some of you may not understand other language. That is why the universal language, unless talking in that. For feeding, again, I'll say don't keep any baby NPO if the baby is 28 weeks and no, don't keep NPO. If you are not confident about our protocols, at least start some feed. And trophic feeding is not 5 ml per kg. It varies from 5 to 24 ml per kg. So the smaller baby, 10 ml, bigger 15, 20, further bigger asphyxia baby, with mild or some distress as high as 20 to 25 ml per kg. So don't say I started with feed 2 ml too early. Document it in ml per kg body weight per day. Nothing like yesterday baby was getting 2 ml too early. Now today I increased to 3 and in the evening I increased to 4. But at least find out how much ml per kg. That is more important. Starting to a 2 kg baby, 5 ml too early is nothing. Sorry, 2 ml too early is nothing. It's 24 ml for a 2 kg baby, 12 ml per kg per day. This is not a feed. This is very less feed for this baby. So don't keep the baby's NPO until and unless REDF for first 24 hours. And that too, REDF, I'm talking of a very small baby, not the bigger babies. Again, if you're not confident, then at least start beginning improving in one gestation, especially 32, then coming down improvement in 30 weeks, 31 weeks, then in 30. This is how you can do every 1 to 2 weekly or monthly, depending upon, your level of, and you can visit the unit in a nearby unit whereby all these babies are being managed for long. Ma'am, when is NPO recommended in neonates with seizures? Okay. So the baby who is having seizures, baby more than, if you are giving the baby on a continuous drip, midazolam drip and all, you have to keep NPO. If the baby is on maintenance anti-epileptic, there's no need to keep the baby NPO. The baby is having continuous seizures, obviously at that time you can keep the baby NPO. As such, baby scissoring more than 2 anti-epileptic, neurological status become poor, you intubate this baby. So you will end up just in a trophic feeding of 10 to 15 ml per kg, 20 ml per kg. That's all. Until unless this baby goes in shock and on inotrop more than whatever you started, dobutamine, dopamine, more than 10 microgram per kg or vasopressin. Then after 10 microgram per kg, because vasoconstriction will happen, alpha receptors of intestines will be more because they have alpha action also. This will cause intestinal vessels vasoconstriction and the feed won't be tolerated. Oxygen demand is more. When the oxygen demand to the body is more, simple rule. Oxygen demand to the body is more. The compensatory mechanism is the more oxygen will go to brain and heart, less will go to the intestines, less will go to the kidney. And any such condition where oxygen demand is more, it is going to go less to the intestines, less to the kidneys, decrease upon the feeds. Baby on ventilator, 60-70% FiO2 requirement. You're not going to give full feeds to this baby. Anything else? Hello? Can we give a feed to patient on CPAP? Yes, you can give feed to baby on CPAP. Usually CPAP babies are on a map of 6, maximum 7. 7 is usually there in the beginning or in a BPD baby. These are the only two babies who are on a map of 7. Very late, 30-40 days BPD babies can be on a 7 map, or a baby who is just born HMD baby on CPAP. HMD baby on CPAP with 7 map, you may not give full feeds, but a baby CPAP 5 to 6, there's no contraindication. You can give as high as full feed, but if you are a beginner, again I'm saying, and you are not confident, some feeding must go on. 20-30 ml per kg must go on. And as such, a baby who is on a map of 7, FiO2 is going to be 70%. So again, the same thing which I told in the previous question. If oxygen demand is more, it is not going to go much to the intestine. So this is called as brain sparing phenomena. Brain is spared, the vital organs, they are spared, but here intestines and kidney are not coming in the vital organ. IVC blood flow will decrease and you cannot give full feed to this baby. Map of 6, 6.5, 50%, 30%, 40, 30% FiO2, 40% full feed can be given. You just have to open your this once the OG is there. Once feed is digested after half an hour or so, you can open it up so that that gaseous distension is released. Which steel phenomena? You're talking of ductal steel phenomena. You're talking of which steel phenomena? I didn't get you. You've written steel phenomena. Anybody else? Tapas or Dr. Pratima? You need to tell me. Hello. Any more questions? Role of human milk fortifier. So if the baby is not gaining weight, there are two schools of thought. It's a debatable question to give or not to give. But if the baby is not gaining weight, baby was to begin with less than 1500 gram, not gaining weight, human milk fortifier to be added. There are two school of thoughts. One would say don't add in all the babies less than 1500 gram because it is going to have long-term implication. Whereas the other one will say, let me first save the baby in shorter term. Long-term will come later on. If I'm not saving the baby in short term, how would I come to know of the long term? So best is if your baby is not gaining weight, you can add human milk fortifier. So don't be in a hurry to add them. But always be in a hurry for feeds. So I think moderators are logged in other zone, north, other than north zone, I think east zone, south zone, or some other zone. This is for the north zone, which is going on. And other zones are being, I think, the same talk by some other person. I don't know. I think, and Dr. Pratima is in other zone. You can keep me asking whatever you want to till she joins, or I'll just finish it off. If there aren't much questions, as I can see now, the participants have started to drop out. As I told you right in the beginning, human brain has got a capacity to concentrate. So if no more, then I'll leave. And I'm open to any question later on also. It is not restricted to this class. You can, my number is there. You can message me and ask. Preferably mail. I love going by the emails rather than WhatsApp.
Thank you so much, Sukshma ma'am. Thank you so much. And students, you can please ask your queries or any queries from the assessment part also, from the breastfeeding assessment or from this one also. You can email or you can WhatsApp me. I'll convey to ma'am.
And they've, I think, already seen how to give palliative feeding, how to give, how to put a OG.
Yes, ma'am. Yes, ma'am. So there were videos. Those who have not yet gone through, they can go through the materials, and assessment will be posted tomorrow. So there were, I think, 80 participants around the maximum time, I think. Thank you. Thank you so much.
Okay. Thank you, Pratima. Thanks once again. I'm just leaving. You can email me if you have any issues. Okay.